Hi, my name is Jaiswal. I'm one of the third-year internal medicine residents here at OSU. I'll be talking about the cardiorenal syndromes today. So, a brief outline of everything we're going to talk about. We'll briefly talk about the definition of cardiorenal syndrome. We'll talk about the 5 subsequent different types of cardiorenal syndrome. I'll briefly talk about the pathophysiology that you should be aware of and thinking about in regards to each cardiorenal syndrome, and then subsequently each one involved in the 5 types of cardiorenal syndrome, the management of cardiorenal syndrome, and then a quick summary, the clinical relevance and how this is applicable to each resident as they participate through their residency training. So cardiorenal syndrome really had began as an umbrella term. This term cardiorenal syndrome increasingly became used more and more, but there was no consistent or well-accepted definition. People would use it interchangeably and didn't have a concise definition describing cardiorenal syndrome or CRS. My formal definition and definition that's kind of widely accepted is it's used to describe acute or chronic dysfunction of the heart or kidneys that can induce acute or chronic dysfunction in the other opposing organ system. So in regards to pathophysiology, in terms of each of them, I want you guys to realize that there's a diverse group of multiple processes happening in each cardiorenal syndrome, but I want you to keep aware of and what to look at when you're clinically evaluating a patient and treating a patient and trying to diagnose them with cardiorenal syndrome, that if they have reduced systemic blood pressure, if they have neurohormonal adaptations, if they have reduced renal perfusion, increased renal venous pressures, or right ventricular dilatation and subsequent dysfunction. So as I previously mentioned, there's 5 different types of cardiorenal syndromes. The first one to me is the most interesting, which is type 1. Type 1 cardiorenal syndrome is acute CRS. It's a rapid worsening and decline of cardiac function, which leads to an acute kidney injury. So the general consensus is that there's 4 different subtypes of the type 1 acute cardiorenal syndrome. One's hypertensive pulmonary edema, 2 is acute decompensated heart failure, 3 is cardiogenic shock, and 4 is actually right ventricular failure. Type 1 cardiorenal syndrome is really determined as an acute heart failure, acute kidney injury appearing. It becomes more severe in patients with impaired left ventricular ejection fraction compared to those with preserved ejection fraction. Here's some brief pathophysiology including and kind of demonstrating type 1 CRS. You'll see that you'll have acute heart disease, you'll have acute decompensated heart failure, you'll have ischemia, you have an ischemic insult including coronary angiography or cardiac surgery, and you'll see that it kind of decreases your cardiac output, it decreases your perfusion, it subsequently increases your venous pressure, and this in turn causes acute renal injury from hypoperfusion, reduced oxygen delivery, necrosis, and decreased GFR. You'll also notice that you'll have elevated BNP, you'll have further hormonal factors that increase in natriuresis and affects the renal function. And in turn, you'll have some humoral signaling that causes some monocyte activation, endothelial activation, cytokine release, and subsequent secretion in conjunction with apoptosis, and it'll also cause renal impairment. So what I want you to take away from this slide is type 1 cardiorenal syndrome is complex, multimodular, and it can cause severe issues and damage to patients. So like I said, to me, type 1 cardiorenal syndrome is most interesting primarily from the management. The goal in type 1 cardiorenal syndrome is to improve the cardiac function. When people come in with decompensated heart failure, pulmonary edema, or cardiogenic shock, your maintenance of therapy is really starting diuretic therapy. If you're lucky, if people are in acute decompensated heart failure, you can utilize diuretics, kind of make them more euvolemic and increase their cardiac function. and really save them. But these people walk a fine line and kind of on the edge of the sidewalk. You may have to reach towards other medications, including vasodilators and inotropic drugs, if your diuretics don't work. You'll often see us in the ICU, and you guys, including the upcoming PGY1s, will see us use inotropic agents in the ICU as we didn't receive a maximum appropriate response to our diuretics to help kickstart our cardiac index and increase diuresis. If you utilize diuretics, vasodilators, and inotropic drugs, and none of them are seeming to make a significant effect on your patient, you may have to turn towards ultrafiltration, ask our nephrologist to come evaluate the patient, and see if ultrafiltration is the goal to make these people euvolemic. One thing I kind of want to tell the incoming PGY1s is when you have acute decompensated heart failure, if you have cardiac shock, do not use beta blockers, as these can make these types of patients worse. Type 2 cardiorenal syndrome's more chronic. It's defined as a chronic cardiorenal syndrome. It primarily begins with cardiac dysfunction, which is long-term heart failure, and it subsequently causes progressive worsening chronic kidney disease due to hypoperfusion. Like I said, the main example that we'll see in type 2 cardiorenal syndrome is chronic heart failure causing subsequent chronic kidney disease. Here's a brief slide that demonstrates the pathophysiology of chronic heart disease subsequently causing chronic kidney disease. You'll see that you can have low cardiac output, you'll have inflammation, endothelial dysfunction, accelerated atherosclerosis. You'll in turn have chronic hypoperfusion, increased venous pressures, possible embolism, causing further insult to kidneys, causing fibrosis, and making progressions of CKD worse. You'll also have uremic retention, anemia, worsening hypertension, electrolyte abnormalities, including abnormalities in calcium and phosphorus levels, and uncontrolled hypertension leading to LVH. The maintenance therapy for type 2 management for cardiorenal syndrome is overall similar to type 1 in the terms that you want to improve their cardiac function and you want to really manage their heart failure appropriately. These people have severe advanced heart failure, and we need to make sure we're doing everything possible to keep that index up, keep your kidneys appropriately perfused, and slow the progression of CKD by managing their advanced heart failure appropriately. Type 3 cardiorenal syndrome is defined more as acute renal cardiac syndrome. It affects the renals first and then in turn affects the cardiac cycle. It's abrupt and primary worsening of kidney function, which in turn causes worsening cardiac dysfunction, leading to possible heart failure, ischemia, and arrhythmias. Some examples of type 3 CRS include acute kidney injury, ischemias, glomerulonephritides, hyperkalemia, and uremia. Here's a brief slide describing the pathophysiology of type 3 cardiorenal syndrome. You'll see that these acute kidney injuries cause decreased GFR. You'll have volume retention and subsequent expansion. You'll have an increased preload, which causes your acute cardiac dysfunction. You'll have subsequent hypertension, sympathetic activation, vasoconstriction, and further electrolyte imbalances with cytokine secretion, similar to type 1, which will in turn cause worsening cardiac manifestations. You can see some elevated biomarkers, including troponins, myoglobins, MPOs, and BNPs. Type 3 management is similar to everything we discussed. We want to make sure these people's blood pressures are appropriately controlled. We want to make sure their electrolyte abnormalities and their acidosis are managed. And if these patients do not improve, you want to consider hemodialysis or CRRT. Type 4 CRS includes chronic renal cardiac syndromes. It is primarily chronic kidney disease contributing to cardiac dysfunction, which can also manifestate as coronary artery disease, heart failures, and subsequent arrhythmias. Some examples you'll see of type 4 that begin with chronic kidney disease will be subsequent damage to the cardiac cycle, including left ventricular hypertrophy, coronary artery disease, and heart failure, as discussed. Here is a brief slide kind of showing the progression of this type of cardiorenal syndrome with the progression of CKD. You'll see that having your patients with the risk factors, including smoking, obesity, hypertension, dyslipidemia, causes chronic inflammation, and it will make your chronic kidney disease progressively worsen. You can go from stage 1 and 2 after having a chronic long-term interstitial damage to progression of chronic kidney disease to stage 3 and 4. With your progression of renal disease, you'll have subsequent abnormalities, including anemias, uremias, electrolyte abnormalities, affections with your nutritional status, elevated BMI. If you cannot control these patients, you don't manage them appropriately, they will all progress into CKD stage 5 and then subsequent dialysis. And then when they proceed to dialysis, you'll realize they also have similar abnormalities, including anemia, electrolyte abnormalities, soft tissue calcifications, toxin buildup, and all of these affect the cardiac function because you'll have cardiac remodeling, you'll have neurohormonal abnormalities, you'll have LVH, you'll have diastolic heart failure, and decreased coronary perfusion and subsequent calcification. Type 4 management is similar to you want to make sure these people's blood pressure are well controlled. Hypertension can make CKD worse. You want to make sure these people's electrolytes and anemias are well controlled. And the real goal here is you want to prevent the progression of CKD as best you can. Type 5 cardiorenal syndrome is more secondary. It's acute or chronic systemic disorders that can cause both cardiac and renal impairments, with the main example being sepsis. Other examples including sepsis are diabetes, amyloidosis, lupus, and other vasculitides. This is a good slide that kind of shows how systemic diseases, as mentioned, will cause these issues. You'll have heart failure and subsequent renal infunction with hemodynamic changes. You'll have hypoxia. You'll have toxin buildups. You'll have heme proteins, contrast medias, and cytokine inactivation that damages both the cardiac and renal systems. The mainstay of therapy for stage 5 cardiorenal syndrome is treating the underlying cause. Make sure people's diabetes are well controlled, and make sure you're doing the best you can for their vasculitides. In terms of sepsis, make sure they have appropriate antibiotic uses. Make sure you treat their vasculitides as indicated. If these people are obviously in septic shock, developing these subsequent organ dysfunctions and having subsequent hypotension, make sure they're on the vasopressive agents they need. Sometimes you may need to reach to inotropes and diuretics to further improve your cardiac and renal systems. And sometimes you also may have to perform renal replacement therapy in conjunction with nephrology. So in summary, when you're thinking about cardiorenal syndrome and you're evaluating a patient in our hospital, the history is key. Make sure you talk to the patient, make sure you understand what's going on, make sure you understand their comorbidities, make sure you understand their medical history, as this will give you a good gauge to see what kind of cardiorenal syndrome you're dealing with. Make sure you listen to their clinical symptoms, make sure you see what's caused their decompensation and progress them into cardiorenal syndrome. When managing cardiorenal syndrome, understand that it's a multidisciplinary team-based approach. You may need cardiology's assistance, you may need nephrology's assistance, and make sure you're always being a team player and making sure you're utilizing your consults as indicated. Understand that the management of cardiorenal syndrome is challenging, and it requires further investigation to make sure you're treating the appropriate cardiorenal syndrome. And finally, make sure you talk to the patient, as these patients usually have multiple comorbidities, and they may not want to go through all the things. We might know the appropriate treatment, we might know what we need to do for the patients, but some patients might not want Swan-Ganz catheters. Some patients might not want LVADs. Some patients may not want to go dialysis. So always make sure you talk to your patients, you inform them of what's going on in the medical care, and include them in the decision-making process. Here are my references. Here are my contact information. Thanks for listening to me talk about cardiorenal syndrome. Feel free to reach out to me and email me at any time you guys have any questions or concerns regarding CRS. Thank you.